the trauma residents at one of the trauma hospitals. So we're going to do breathing next. So in breathing, you'll listen to the patient's lungs to see if they have equal bilateral breath sounds. If they do not, it depends on whether the patient is an extremist or if they're stable enough to get a chest x-ray. If they do not have equal breath sounds, it could either mean a hemothorax or a pneumothorax. At this point, you'll prepare to put in a chest tube. To do a chest tube, you need to make sure you have all the equipment. So you'll have the chest tube itself, the chest tube insertion instruments, as well as lidocaine, the Pleurovac. Patient will be on the bed, so you need to make sure that you have some sort of surface to put this on. There are not a lot of Mayo stands in a trauma bay, so one of the alternatives would be to use one of the linen bins, and you can place all your stuff on there, so you can have the area accessible to place the chest tube itself. Another thing about placing chest tubes is chest tubes can be placed either emergently after listening to the person's breath sounds, noting one side is decreased compared to the other side, as well as the patient being unstable. In these situations, you need to place an emergent chest tube. The other situation is in a stable patient who you obtain a chest x-ray and you notice either hemothorax or pneumothorax, and at that point you have a more controlled environment to place the chest tube itself. Important things about placing a chest tube is, number one, if you need to place a chest tube, is make sure the Pleurovac is set up. Either you assign someone to set up the Pleurovac, or if you have time, you set it up yourself. Another thing that's really important about placing the chest tube itself is having suction set up. So in the airway section, we had a suction set up for suctioning the airway.
Stay away. This is my suction for the airway.
So do not use that one. Have a second suction set up for the chest tube itself. And then it goes to the basics of placing a chest tube, which will be discussed
later. I would just want to add a few things with it. So if you look over here, there's this cart. As we saw from the airway video, there are 2 trauma bays. We have 4 trauma bays and 2 beds in each bay. So this cart is only on one side. So if you're on the smaller side bay, the one over there, you can see that there's no cart. So you need to grab all your supplies from here and bring them over to wherever you're putting your chest tube. Another little just finesse point is, like, let's say the person comes in a traumatic arrest that happened yesterday. So people are going to do CPR. So what I would recommend is having the stand for people doing CPR on the patient's right side, because on the left side, let's assume for the sake of argument that it's a penetrating traumatic arrest. On the left side, whoever's putting in this chest tube may need to convert to doing an ED thoracotomy, and this is more than likely the more important side. So if you have people doing CPR on that side, that frees you up to do the chest tube, and you're not doing it around somebody doing chest compressions. So that's a safety thing, as well as it frees you up to have the ability to do a bigger procedure if indicated. The other thing about that is who's doing CPR on which side can also switch. So once the person gets the chest tube in on the left side, often we do bilateral chest tubes. So then whoever's running the code should basically call an audible and say, on this next round, we're switching CPR sides so that the person on the right side can get the tube in. Now, obviously, the person on either side, no matter who's doing compressions wherever, should be prepping to the extent that they can to get the tube in. You shouldn't delay doing everything just because people are doing compressions, but most of the time in reality, between opening the kit to get the knife out, between getting the tube and clamping it and all of that, and it takes enough time so that there's been already like a post-check and chance for the people doing manual compressions to switch. All right, that's pretty much all we can say about breathing.